Welcome to the deep dive. Today, we're investigating a condition that, well, it turns the simple act of eating into a source of chronic anxiety and suffering.
Mm.
We are diving deep into gastroparesis. If you, or, anyone you know, has struggled with feeling impossibly full after just a few bites, or wrestled with chronic, debilitating nausea.
It's a daily reality for so many.
Yeah,
Your stomach just isn't doing its job.
that's it, exact.
That really is the core issue. Forget the complicated medical jargon for a second. Gastroparesis is simply delayed gastric emptying.
Delayed emptying.
Right. Food just sits in the stomach for hours instead of moving naturally into the small intestine. So the definition is you have this abnormally prolonged retention of contents, but there's no physical blockage. Nothing's actually in the way.
And what immediately jumps out from the research is just how often this is linked to a single, very common chronic illness.
Exactly. The key context you need right away is that fully half of all diagnosed cases are what we call diabetic gastroparesis.
So it's a complication of diabetes.
It is. It's caused by autonomic enteric neuropathy, which is a fancy way of saying nerve damage has specifically occurred within the gut's nervous system. It's like the stomach's internal electrical system. Its pacemaker has just been disrupted.
So our mission today is to cut through the complexity of this. We're going to look at the mechanics of why the stomach stalls. We'll establish a highly practical severity classification system that makes this easier to think about.
Which is so useful for understanding management.
Right. And then walk step by step through the diagnosis and the full spectrum of management, from simple dietary shifts all the way to advanced surgical interventions.
So let's unpack the mechanism. If it's not a physical blockage, what is actually failing inside the stomach?
It's entirely a coordination problem. The proper gastric neuromuscular synchronization is lost.
Okay.
So imagine your stomach is this sophisticated blender that also has to push food out. This failure can show up in a few different ways.
Give us the visual on that. What are these failure points? Well, you might see the powerful grinding muscles, the antral contractions, just decrease in frequency. They aren't crushing the food enough.
So a weak blend cycle.
A very weak blend cycle. Or the top part of the stomach, which is supposed to contract and squeeze everything downward, might just lose its power. And finally, the exit valve, the pylorus, can spasm.
It stays shut.
It stays tightly shut due to these increased pyloric pressure waves. So basically, the mixer slows down, the squeezer fails, and the exit door is just glued shut.
So if diabetes is the cause in about half the cases, what's going on with the other half?
The non-diabetic causes are more varied and less common. We see links with autoimmune conditions like scleroderma or sometimes damage to the vagal nerve after an abdominal surgery.
Okay.
Other things, much less frequent, are enteric neuropathy, amyloidosis, even perineoplastic syndromes. But here's the most frustrating part.
What's that?
For the majority of these non-diabetic patients, the cause remains idiopathic.
Which is doctor speak for.
We just don't know why.
And we can't forget to check the medicine cabinet. I saw that many common drugs can either mimic this or make it much worse.
Absolutely. This is such a critical step. Patients often don't realize their existing medications are part of the problem. Muscarinic, anticholinergics, narcotics,
Opioids.
right? Opioids, calcium channel blockers, and even some tricyclic antidepressants are all known culprits that can really delay gastric emptying.
So checking that drug list is step one.
An essential step. Now, if you're trying to understand the full spectrum of this disease, this next part is maybe the most critical takeaway from our sources.
Okay.
There's a brilliant, practical 3-grade classification system. It defines severity based on how manageable the condition is.
I found this framework so helpful because it's not just about symptoms, it's about the patient's functional level. Let's start with grade 1.
Grade 1 is mild gastroparesis. These patients, they have symptoms, but they are relatively easily controlled.
And they can maintain their weight.
Yes. They're able to maintain weight and nutrition with just minor modifications to their diet. They're functional, relatively stable.
Then we get to the middle ground, grade 2. This is called compensated gastroparesis.
Right. This patient is struggling more, they have moderate symptoms, and they only get partial control even with medications.
But they can still eat.
They can still maintain nutrition through really dedicated dietary and lifestyle adjustments, but here's the key difference. They have rare hospital admissions.
And that brings us to grade 3, the most severe. This is essentially gastric failure.
This is a different world. The patient has crossed a functional threshold. This is the truly refractory state. Symptoms just persist despite all the medical therapy we throw at them.
And the defining feature here.
The inability to maintain sufficient nutrition by mouth. This leads to frequent emergency room visits or hospitalizations for dehydration, malnutrition. It's this category where those really high-risk advanced interventions have to be considered.
Let's pivot to diagnosis then. A patient comes in with that classic cluster of symptoms, postprandial nausea, feeling full really early, vomiting. What's the first thing a physician has to do?
The first non-negotiable step is to rule out a mechanical obstruction.
You have to prove nothing is blocking the exit.
You absolutely have to. You can't diagnose gastroparesis until you prove there isn't a physical blockage like an ulcer or a tumor. If there are red flags, weight loss, bleeding, you have to get an endoscopy or a CT scan immediately.
Are there any physical signs, things a doctor can find on an exam?
Yes, sometimes. A physician might notice abdominal distension or some tenderness in the upper abdomen. The classic sign, though it's less common, is the succussion splash.
What?
A succussion splash. If the doctor gently shakes the patient's abdomen and hears a sloshing sound over the stomach hours after a meal,
Oh, wow.
it means there's retained fluid and gas. It's a definite sign of delayed emptying.
So how do we definitively confirm it then? If basic labs aren't going to give us the answer.
All right, there's no blood test for this. While glucose and glycated hemoglobin are essential for the diabetes question, the gold standard test is the gastric emptying scan, scintigraphy.
And what does that involve?
It involves eating a standardized meal that's been tagged with a tiny bit of a radio label. Then we take pictures of the stomach over several hours to see exactly how slowly that food is moving out.
I also saw an alternative mention, something called a smart pill. Why would you use that instead of the scan?
The wireless motility capsule, the smart pill, is for when you suspect the problem isn't just in the stomach.
The whole system might be slow.
Exactly. If the doctor suspects diffuse motility issues through the whole GI tract, stomach, small intestine, colon, that capsule gives you a much broader picture of transit time.
So once we have the diagnosis and we know the severity grade, the management follows a pretty clear path, starting with the basics.
Yes, it's a stepwise approach. We begin with immediate supportive needs, correcting any electrolyte imbalances, getting tight blood sugar control for diabetics.
Which can help on its own, right?
It can dramatically improve symptoms. And then, most importantly, dietary modifications.
What are the specific food rules patients have to follow?
The key is easy processing and high frequency. So patients switch to small, frequent meals 5 to 6 times a day, half-size portions.
And the diet itself?
It must be low fat and low fiber. And there's a clear reason why. Both fat and fiber are scientifically known to delay gastric emptying time. They're the enemy of a slow stomach.
So when diet isn't enough, we move into pharmacology, into drugs, starting with what are called the prokinetics.
These are the drugs that try to restart the movement. And we usually start with a class called dopamine 2 antagonists like metoclopramide and domperidone.
Metoclopramide is effective, but it comes with some really serious warnings.
It does. There are critical side effect risks that need close monitoring. The big one is extrapyramidal symptoms. We're talking involuntary movements, restlessness, tremors.
And there's a long-term risk too, isn't there?
Yes. And it's the scariest part. If it's used for too long, there's the specter of tardive dyskinesia, a movement disorder that can be permanent. Permanent, uncontrollable, repetitive motions. It's a very serious trade-off.
Domperidone avoids a lot of those neurological side effects, but it has its own major warning.
A huge one. It's safer from a movement disorder perspective, but the severe caution here is cardiac. It can prolong the heart's electrical cycle, which risks a potentially fatal arrhythmia.
So you need an EKG.
Strict EKG screening and monitoring are absolutely mandatory before starting that drug.
Okay, then we have another class, the motilin agonists, like erythromycin. It's an antibiotic, right?
It is, but it also has this prokinetic effect. The problem is what's called tachyphylaxis.
Meaning?
It means the body gets tolerant to it very quickly. It basically stops working over time, especially when taken orally. Azithromycin is similar, but maybe with less cardiac risk.
And we should probably just briefly mention the 5-HT4 agonists.
Yes, and they're a cautionary tale. Cisapride was the most well-known, and it was withdrawn from the market because of the undeniable risk of cardiac arrhythmias. It shows the danger of trying to fix the gut at the expense of the heart.
So what if all of these prokinetics fail? What's next?
Only after prokinetics have failed should we consider antiemetics as second-line therapy.
So these don't fix the movement.
No, these just treat the nausea. They don't fix the underlying motility problem at all. We're talking about drugs like prochlorperazine, promethazine, or ondansetron.
And we also have to think about specific patient groups like the elderly or pregnant women.
Absolutely. Elderly patients are much more prone to the adverse effects from both metoclopramide and erythromycin.
Yeah.
And for pregnant patients, while those two are considered Category B drugs, meaning generally safe, the risk still has to be weighed very carefully.
Now we get to the grade 3 patients, the ones with refractory gastric failure, not responding to diet or drugs. This is where the advanced therapies come in.
And this is where it gets really interesting and, frankly, a bit frustrating.
How so?
Well, let's look at gastric electrical stimulation, or GES. It sounds so high-tech and promising. A stomach pacemaker.
It does. But what does the data say?
The data is shockingly weak. A huge meta-analysis showed no significant difference in overall symptom severity scores between patients who got GES and those who didn't.
None.
None. One controlled trial did find an improvement in vomiting scores, but, and this is critical, it failed to show improvement in the actual speed of gastric emptying or the patient's quality of life.
So the sickest patients are relying on treatments that don't have solid proof.
Precisely.
Yeah.
And what about trying to open up that tight exit valve, the pylorus?
Right, there was some buzz around Botox injections for that.
There was intrapyloric botulinum toxin. Open-label trials suggested it might work, but when they were put to the test in rigorous randomized controlled trials,
Gold standard.
the gold standard of medical proof, they failed completely to show any sustained improvement. So Botox is out.
But newer endoscopic surgeries are still emerging, like something called GPOM.
GPOM, gastric peroral endoscopic myotomy. It's a procedure to endoscopically cut the circular muscle of the pylorus. Conceptually, it makes sense.
Yeah.
But we have to emphasize that the current evidence on its efficacy is exclusively from uncontrolled studies, case series. We have a critical, urgent need for controlled studies to really validate this invasive approach.
If a patient needs a full surgical intervention, they might get a surgical pyloroplasty.
Right, which is a surgical widening of that exit. It has shown some short-term improvement, maybe for about 3 months, which can offer a necessary temporary fix for the most severe cases.
But with all of these procedures, GES, GPOM, pyloroplasty, there's one serious complication that can just swap one severe problem for another.
Yes, this is the big one. Any procedure that significantly alters the stomach's anatomy or its timing risks the development of dumping syndrome.
So instead of being too slow,
Everything is suddenly too fast. Instead of food moving too slowly, it just rushes into the small intestine. You've traded chronic retention for chronic rapid transit, which has its own whole set of debilitating symptoms.
So let's sum this up. We've established that gastroparesis is delayed emptying without a blockage. It's often caused by diabetes, and it's graded in severity from mild to outright gastric failure.
And I think the core learning points are twofold. First, management really relies on the severity grading system. You start conservatively with a diet low-fat, low-fiber, and glucose control.
And second,
Second, when you move to the drugs, you have to be hyper-aware of the high-stakes side effects of the prokinetics, whether it's the permanent movement disorders from metoclopramide or the cardiac risks from domperidone.
and we've identified this crucial paradox. For the patients in gastric failure grade 3, the invasive treatments like GES and GPOM are being used, but they often lack that robust, randomized, controlled trial evidence, despite the very high risks involved.
Including dumping syndrome, which raises an important question for you to think about. Since these complex surgical and endoscopic options are being used for the most severe refractory cases, but the data to validate them is so weak, and considering the life-altering risk of dumping syndrome.
What should we be looking for?
What essential criteria or metrics should future randomized controlled trials prioritize to finally validate these treatments? Should they focus purely on symptom relief? Or must they prove actual, sustained acceleration of gastric emptying to justify such a risky intervention?